Yes, Dr. Neelavati has joined.
Shall we wait for 5 more minutes?
Yes, madam. We'll wait
Good
for 5
evening.
minutes.
Good evening.
Good evening.
ಕೊಟ್ಟಿದೆ ಪನಿ.
Hello, good evening, everyone.
गुड इव्हनिंग मॅम.
Hello, good evening.
मयुरी झाला आहे. हेमंत सर पण
मी एसएबीसीच्या लॅपटॉप वरूनच होतोय.
ओके ओके हा हेमंत सर पण जॉईन झाले का म्हणजे आपण
गुड इव्हनिंग सीमा.
गुड इव्हनिंग हिलो.
हेमंत सरांना फोन केला होता. हे म्हणतात
अच्छा.
तुम्हाला चेक करायचं आहे तर ते म्हणाले मी चेक करतो. तर
अच्छा.
अजून तरी नाही झाले वाटते.
पहिले मयुरेशच आहे ना प्रेझेंटेशन.
हो पहिला मयुरेश.
हो, पहिले मयुरेश सर.
भावेश किंवा उमा मॅडम उद्यापासून इलेक्शन सुरू होते त्याचं पण एक रिमाइंडर देऊन द्याल सगळ्यांना.
हो 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 1 ऑगस्ट ना उद्या.
हा उद्या 1
1
ऑगस्ट
ते 5 आहे ना. 1 ऑगस्ट ते 5 ऑगस्ट.
जस्ट गिव्ह देम रिमाइंडर. जरी आपण व्हॉट्सअप वर देतो नाव एव्हरीवन हॅज लॉग्ड इन तर वी कॅन.
येस येस.
बागेश्वरी. मॅडम आधी तुम्ही बोलणार आहे ना उमा मॅडम?
हो, मॅडमच बोलतील. मी जस्ट वेलकम करतो मॅडमला. हे करतो.
हॅलो.
हॅलो, गुड इव्हनिंग मॅडम.
गुड
मॅडम
इव्हनिंग. गुड
जॉईन.
इव्हनिंग. येस गुड इव्हनिंग. ऍक्च्युली आय एम इन कलकत्ता. मी
अरे वा.
इव्हनिंग माया मॅडम.
पोचले मॅडम.
ट्रेनिंग.
गुड
हॅलो.
इव्हनिंग मॅडम.
गुड इव्हनिंग. गुड इव्हनिंग आशिष. गुड इव्हनिंग नीलावती.
हॅलो.
अरे तू
आशिष
काय
is in-
ओटीत अजून?
हा,
ओटीत.
टायर
हो
वरती.
आता
ओके
एक
ओके.
अपेंडिक्स इंड्यूस करायचंय.
हा 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 ओके. अच्छा.
राम राम मॅडम.
मुथा सर
बालेराव
आहेत.
मॅडम राम राम.
येस येस. नमस्कार सर. सो नाईस टू सी यू सर.
गुड इव्हनिंग सर.
मॅडम
गुड
काय
इव्हनिंग
म्हणता?
सर.
कलकत्त्यामध्ये काय करताय?
सरांचा जस्ट मुलांचा साखरपुडा झाला म्हणाले.
कलकत्त्यामध्ये सर मला इन्व्हाइट केलंय. इंटरनॅशनल आर्ट एक्झिबिशन आहे. तर तिथे त्यांनी मला डेमॉन्स्ट्रेशनसाठी आणि एक्झिबिशनसाठी इन्व्हाइट केलं. सो आय एम हिअर
अरे
फॉर
वा.
आर्ट फॉर 4
ग्रेट.
days. येस.
मग तुम्ही आता परत आल्यावरती तुमचं फेलिसिटेशन करावं लागेल. परत
इट्स माय ऑनर
एवढ्या
सर.
मोठ्या
पण छान.
आर्ट एक्झिबिशनला.
हो हो आणि
मॅडम इज
इंटरनॅशनल
अवर
आहेत.
येस येस.
इंटरनॅशनल
मॅडम
आहे
इज
ना. मी
स्प्रेडिंग
वाचलं
हो
होतं
हो
SAPC
हो.
त्याबद्दल.
एव्हरीवेअर.
काय म्हटलं सर?
ग्रेट. म्हणजे वाचलं होतं त्याच्याबद्दल.
हो हो
मला
हो.
आर्टचे सगळे नोटिफिकेशन येत राहतात फेसबुक वरती.
ओके
त्याच्यामध्ये एकाने लिहिलेलं होतं की
ओके
कलकत्ता आणि आय थिंक सो देर इज वन इन दिल्ली ऑल्सो इन नेक्स्ट मंथ ऑर समथिंग.
ओके. सर तसं चालूच असतं खरं.
इंटरनॅशनल आर्ट एक्झिबिशन म्हणून काहीतरी लिहिलं होतं त्याने.
ओके ओके. हे कलकत्त्याचं पण खूप
मिलिंद
मोठं आहे. भरपूर लोक आली आहेत. साऊथ कोरिया, स्वित्झर्लंड इकडनं तिकडनं आली आहेत लोक. आणि
ग्रेट
त्याच्यामध्ये
मॅडम.
अपॉर्च्युनिटी मिळाली. छान वाटलं.
नाही,
म्हणजे
ग्रेट
दॅट्स वाय
ग्रेट ग्रेट.
दॅट्स वाय आय थॉट की आपण लेट्स अटेंड इट. म्हणजे 3-4 दिवस जातात. पण मग ठीक आहे. त्याला काही पर्याय नसतो. करायला लागतं.
माझं मिलिंदशी बोलणं होतं खूपदा. मिलिंद
हो हो हो. ओके. ते
मुळे.
तुमच्याच इथे राहतात ना सर ते ऍक्च्युली
ते
तुमच्या
आमच्या सोसायटीमध्ये राहतात.
सोसायटीत. हो हो.
कारण मी खूप सारे आर्टच्या ग्रुपमध्ये आहेत म्हणजे फेसबुक आणि याच्या. तर तो विचारत
ओके.
होता की बाबा कसं काय म्हणजे म्हटलं आय लव्ह आर्ट. सो मी सगळं बघत असतो ते त्या गोष्टी.
अच्छा. ओके. ग्रेट ग्रेट. हा. मोहित
असं
सर तर
त्याच्यासाठी
बाप माणूस ना. भारी आहे
ते
एकदम.
ते तर अल्टिमेट आहे.
हॅलो
हो हो.
संदीप.
या
डॉक्टर मोहन
हाय
पाठक
मोहन,
बोलतो.
हाऊ आर यू?
मॅडमचं मी एक्झिबिशन बालगंधर्व मध्ये बघितलं होतं.
हो
अतिशय
हो.
सुंदर
येस.
होतं. It's a
Oh,
world class only. That's why she is invited for international exhibition.
थँक्यू सो मच सर.
पुण्यात मी सरांना पण भेटलो होतो आणि मॅडमना पण भेटलो होतो आणि एक्झिबिशन
Yes.
पूर्ण बघितलं होतं.
येस थँक्यू सो
छान
मच सर. थँक्यू. येस.
Congratulations.
भावेश सुरू करायचं का?
Shall we
Yes,
start?
yes, sir.
Shall we start?
Yes, madam.
हो करू
I
शकतो.
think
किती
so,
वेळ
madam.
झालेत ना?
6:36 झालेत.
हेमंतचं झालंय का विचारायचं होतं. फक्त आय कॅनॉट सी हेमंत.
नाही काही प्रॉब्लेम नाही मॅडम. He will join. So we'll
Okay.
start.
Okay, let's start then. Yeah.
Good evening,
Very,
everyone.
very warm
So-
welcome to all. We are here to conduct our monthly clinical meeting in the form of this webinar. As anesthesiologists, we are all trained to handle challenges from day one in the OT, and so have we. So I welcome all ISA office bearers and SAMS office bearers who have joined us. This webinar platform is a wonderful thing our SAMS office has created. It not only makes communication easy, it helps us reach out to people in distant places, which otherwise wouldn't have been possible. SAPC has grown a lot in the last few years, and there is commendable work going on. And I'm sure in the farthest corners of our area, this happens. We try to keep a track of all the good work that is going on around us. And that is when we found out these two cases worthy of praise. So there is a lot to initiate discussion and enhance our knowledge through them. That is why, without wasting further precious time, I hand over to Dr. Nilavati Kasnare to start the webinar. Dr. Nilavati.
Thank you, madam. Thank you.
Hello.
Yes, ma'am.
You can start it. Nilu.
Yes, ma'am. Yes, ma'am. Sure. Good evening, everyone. Myself, Dr. Nilavati Kasnare, welcome you all for today's webinar. That is unique case presentation will be presented by our own SAPC member. This activity is organized by our Society of Anesthesiology, Pimpri-Chinchwad, in association with Society of Anesthesiology, Maharashtra State. Dear friends, as we all know that our branch is a very active branch. Every month we carry some activity, whether online, physical, academic, or non-academic. As you all know, our branch successfully organized Yuva Mahakon last month only. I take honor to welcome our today's chairperson, Dr. Sandeep Mutha sir. I also welcome our own office bearers who have taken efforts to organize today's webinar. President Dr. Bhavesh Seth sir, Secretary, respected Uma Deshmukh Madam, Treasurer Dr. Bhageshri Vabe, GC member Dr. Maya Bhale Rao Madam, and immediate past President Dr. Shobha Bhatkar Madam, and Trust President Dr. Sumit Lad sir. I request all the participants to keep themselves muted during the session. They can keep their videos on if they are at appropriate places. Question and answers will be taken at the end. You can type your questions and you can appreciate the speakers in the chat box. All questions will be taken at the end. Dear friends, now I would like to introduce our esteemed chairperson, today's chairperson, Dr. Sandeep Mutha sir. Dr. Sandeep Mutha sir, who is a very multi-talented and dynamic person who does cardiac, regional, and general anesthesia also. Dr. Sandeep Mutha sir is a director of Pune Anesthesia and Critical Care Private Limited. He is director of Medipav. Sir is HOD. Sir is HOD at Pune Hospital and Research Center. Sir was past president and past treasurer of ICTA Maharashtra. Sir is secretary at Society of Regional Anesthesia. He is a past secretary of ISA Pune, and sir has delivered many lectures at multiple conferences, national and international. Sir has did more than 20 publications. Sir is having a book chapter on intracranial hypotension and cervical epidural blood patch. Sir was organizing secretary at ICTA 2006, 2013, 2017 at Aura. and sir is having special interest in teaching cardiac, bariatric, regional anesthesia and technology. And just now, as he said, he is having an interest in photography, nature, and trekking and hiking. Welcome, sir. We can start presentation. Now,
thank you,
our
Neela.
first presenter is, we all know that myasthenia gravis is a very challenging, for us. Myasthenia gravis is an acquired condition involving neuromuscular blockade and subsequent muscle weakness. And it is very difficult to manage these patients in the perioperative period. They have abnormal response to all our anesthesia drugs. Dr. Mayuresh Umalkar is a young, enthusiastic anesthesiologist who is going to present this case, myasthenia gravis patient posted for shoulder surgery under the regional anesthesia. Dr. Mayuresh Umalkar is a consultant anesthesiologist at Dhanashri Hospital, Chinswad. He is a freelancer anesthesiologist in PCMC. He did his MBBS from SV and GMC Yavatmal, and he did his DA from Madurai Medical College. He did DNB from Ruby Hall Clinic, Pune. He did fellowship in regional anesthesia at Ganga Hospital, Coimbatore. He did European diploma in regional anesthesia. Now, I request Mayuresh, kindly start your presentation.
Thank you, madam. I will start my screen sharing now. Am I audible?
Yes, Mayuresh, you are audible.
Yeah, thank you.
We request everybody else to please keep themselves muted to avoid the disturbance.
Okay. First of all, thank you, Society of Anesthesiologists, Pimpri Chinchwad and SAMS for giving this opportunity to me. I will not waste any time and will start my topic. So today's topic is anesthesia for shoulder arthroscopy in myasthenia gravis patient. Preoperative evaluation, 62-year-old female came to our hospital for left shoulder pain and restricted shoulder movement. On clinical examination and MRI, she was having left rotator cuff tear and has been posted for arthroscopic rotator cuff repair shoulder surgery. Routine blood investigations and physician fitness were done. She was a known case of myasthenia gravis since 1 year. She was at that time, her symptoms were ptosis, difficulty in eating, coughing while eating, jaw heaviness, reduced power in proximal muscles of legs and arm. So they did the antibody testing there for myasthenia gravis, which came positive, and their physician started her on pyridostigmine 60 mg 4 times a day, azathioprine 50 mg 3 times a day, and tablet prednisolone 10 mg a day. With this treatment, she showed improvement, and her doses were then reduced gradually to tablet pyridostigmine 30 mg 3 times a day. When she was posted for surgery, at that time, she wasn't having any symptoms specifically of myasthenia gravis because it was well controlled on the pyridostigmine. She was just having left shoulder pain and restricted left movement. Relatives have been informed about the myasthenia gravis and its anesthesia concerns and risk involved. So now before going ahead of how I proceeded with the case, we'll discuss about the myasthenia gravis. Myasthenia gravis is chronic autoimmune disorder that leads to skeletal muscle weakness or fatigability due to disruption at the neuromuscular junction. What are the main causes? Mainly it is autoimmune and autoantibodies against the acetylcholine receptor, anti-MuSK antibodies. Then thymus gland abnormalities are in 75% of patients. There is either thymus hyperplasia or thymoma. Genetic predisposition, family history of autoimmune disorder may increase the risk of myasthenia gravis. Drug-induced myasthenia gravis, though rare, so certain drugs such as penicillamine, interferon alpha, or immunomodulators can trigger or worsen the myasthenia gravis. Signs and symptoms of myasthenia gravis: ptosis, diplopia in eyes, face and neck, facial weakness, difficulty in chewing, smiling, or swallowing, slurred or nasal speech, weakness in arms or legs, mainly often proximal, difficulty in climbing stairs or lifting arms, respiratory, shortness of breath, risk of respiratory failure in severe cases, like in myasthenia crisis cases. Course of the disease, onset can be sudden or gradual, more common in females age less than 50-year-old. Symptoms worsen with activity and improve with rest. Many patients experience ocular symptoms first, like ptosis, diplopia, and then progress to generalized myasthenia gravis, like weakness while difficulty in breathing, difficulty in eating, then weakness in legs and arm. Red flag signs of myasthenia crisis: severe respiratory muscle weakness, which may require ventilatory support. This can be triggered by infection, surgery, medications, or stress. Preoperative. Now, what is the preoperative optimization for myasthenia gravis patient? Check the disease severity. There is a myasthenia gravis Federal American classification which can tell us about the severity of the disease. Continue the pyridostigmine up to the day of surgery. Consider ICU backup or postoperative ventilation if high risk or any major surgery. If possible, quantitative train of 4 monitoring if neuromuscular blockers are used. Crisis risk: myasthenia crisis, weakness due to under medication or stress, or infection or surgery. Cholinergic crisis, over medication with cholinesterase inhibitors. Now, what are the anesthesia concerns for myasthenia gravis? Since there are a lot of antibodies at the muscular junction of the muscular side of the NM junction, these patients are very sensitive to non-depolarizing neuromuscular blockers such as rocuronium, vecuronium, and very resistant to depolarizing agents such as succinylcholine. So, in case of muscle relaxation management, prefer to avoid neuromuscular blockers whenever possible. If neuromuscular blockers are required, very low dose of rocuronium with tenofovir monitoring should be used. Sugammadex is preferred for reversal if rocuronium used. In case of reversal agents, neostigmine is less effective due to already high acetylcholinesterase at the synapse due to the antibodies, and sugammadex is effective. But point to be noted, though sugammadex can be used for the reversal of this patient, but whatever the residual weakness can still persist due to the underlying disease. Many studies have published that sugammadex they are used effectively in myasthenia gravis patient, but this point should be noted that residual weakness can still persist due to the underlying disease. Ideal anesthetic plan will be avoid muscle relaxant whenever possible. Use short-acting agents like propofol, sevoflurane, remifentanil, fentanyl. TIVA or regional anesthesia is preferred. Sugammadex for rocuronium if reversal if used. ICU backup if myasthenia gravis is severe or prolonged surgery is anticipated. Now, generally at Dhanasri Hospital, Chinchwad, daily we do 1 or 2 shoulder scopies. Yearly we do around 400 to 500 surgeries. Initially, we used to do all these cases under general anesthesia and general anesthesia along with interscalene and supraclavicular block. Reasons being, we keep the patient in lateral position with operating arm elevated with the pulley. It is little bit awkward position for the patient. We do all Bankart and shoulder cuff surgeries under lateral position only. Continuous irrigation of normal saline goes on, so the patient sometimes get wet and they feel uncomfortable. Surgeons and also patient also comfort is in general anesthesia, so that there should not be any movement of the patient, and patient request for the general anesthesia. Now, in this case, my plan for shoulder arthroscopy in myasthenia gravis. First, I decided that regional is preferred, so I just thought of interscalene block with superficial cervical plexus block and supraclavicular block with conscious sedation. I should go ahead with this. And another plan was in my mind that if this plan fails, then intravenous and deep inhalational induction without muscle relaxant with supreme LMA and interscalene block for pain relief. This was my 2 plans. Then, after discussion with the surgeon, relative, and patient, we had decided to go ahead with the planning, that is interscalene block with superficial cervical plexus block and supraclavicular block with conscious sedation. In this case, patient cooperation was of utmost importance. And as we discussed with the patient, she said she can lie down in lateral position for 2 to 3 hours. And so we decided with that plan. We decided to go ahead with that plan, and she was extremely cooperative throughout the surgery. How I did it: on preoperative examination, all routine labs were done. They were normal. ECG was suggestive of left bundle branch block. 2D echo was normal study with LBF 55%, chest X-ray was normal, vitals were normal. So I kept the patient in supine position with pillow beneath both the shoulder, and I turned the head on the right side to get the good access of the left side of the neck for the block. I generally do block like this only. In Ganga Hospital, we used to do block like this. So I have been trained from that institute. I am practicing this block. So now how I gave the block with the UHG guided left interscalene block given. I used 0.5% bupivacaine 6 ml and 2% lignocaine with adrenaline 6 ml by out of plane technique. And UHG guided superficial cervical plexus block given 2% lignoadrenaline used 3 to 4 ml. UHG guided supraclavicular block I have given mainly in the coronaris pocket. Coronaris pocket means it's near at the junction of subclavian artery plexus and the first rib. So to block the C8 T1 plexus, because in interscalene block we can block only C5, C6 and C7 plexus. C8 T1 plexus is required to block the posterior cord or the ulnar side of the hand, though it is not required for the shoulder scopies. But since we keep the patient in lateral position with the hand elevated in the with the help of pulley, so that's why I generally give this block. So total dose I have used 14 ml of bupivacaine, 10 ml of lignoadrenaline, well within the toxic dose. So this interscalene block sonography anatomy I want to show you. This is a traffic light signal sign. You can see the C5, C6 and C7 roots and sternocleidomastoid on the medial side. So generally I give out of plane block and 10 to 12 ml of drug with ultrasound guidance is enough to block this interscalene to give the interscalene block. So after giving the block and after confirming the block action, we gave the patient in lateral position, and O2 was started at the 6 liter per minute with normal oxygen mask. I just kept the EtCO2 tubing inside the oxygen mask and stick to it, so that at least I will get her breathing readings or little bit EtCO2 readings. Monitor attached where ECG, SpO2, blood pressure, pulse rate and EtCO2. Patient was draped properly to avoid any seepage of irrigation fluid, and cotton was kept at the pressure point at the legs and the lower arm. Then intraoperatively, patient was rock stable. Surgeon was also comfortable with the blood pressure. You can see I started initial injection pantoprazole, ondansetron and cefuroxime was given in the operation theater itself just before the giving block. Injection midazolam 1 milligram IV I have given, and injection dexmed 50 mics in 100 ml NS was given over 50 to 20 minutes. Patient was literally slowing during the surgery. Intraoperatively 2 NS were given slowly, and the surgery lasted for about 1.5 hours, and total duration was about 2.5 hours. Post-operatively, patient was fully conscious, awake, without any pain, and NBM was broken immediately after 1 hour because she was completely conscious, no pain, nothing. After this, I have done at least 8 to 10 cases under regional anesthesia, and it was a wonderful experience because these patients are all diabetic, hypertension, with difficult airway, elderly. So it reduces your stress also while giving this. Once your block given and if it's acted very well, then it definitely very stressless situation, and patient comfort also is very good. Now just this is shoulder nerve supply. If you see, most of the shoulder is supplied by C5, C6 and C7, C5, C6 and C7, and the superficial cervical plexus C3, C4. So, and C8 T1, as I told you, I generally give supraclavicular block to block the ulnar side of the arm and forearm. Main nerves of the shoulder are axillary nerve C5, C6 and suprascapular nerve C5, C6. These are the main nerve supply which supplies to the shoulder and the muscles. Just want to show you the so anatomy of the interscalene block and its distribution. Generally, I give out of plane block because if you give block from the lateral side, there are dorsal scapular nerve and long thoracic nerve which can get injured while giving on the out of plane. So I always prefer out of plane technique, and 10 to 12 ml of drug is enough. Interscalene block can have a lot of complication. Phrenic nerve block is almost 100%, even if you are giving 5 to 10 ml interscalene phrenic nerve block is phrenic nerve palsy, temporary diaphragmatic paralysis is always there. So always give don't give more than 12 to 15 ml of drug in interscalene block. Then block distribution, you can see mainly it covers the shoulder, arm, and forearm, but inner side is not covered by the interscalene block. So that's why I give the supraclavicular block, and some intercostal block. Interscalene will act to completely block the shoulder. These are my references. Thank you for giving me opportunity to talk. Hello.
Thank you, Mayuresh. It was a very nice presentation. Now I request our chairperson, Dr. Sandeep Muthasar, for your expert comments.
Madam, can I have one question
Yes,
to
sure,
Dr.
madam.
Mayuresh? Yes.
Yes, madam. Yes, madam.
Good evening. Just
Good
as you showed the USG the picture for that interscalene block, can you show it as a supraclavicular block? How you give?
Ma'am, sorry, I couldn't get the image actually. Supraclavicular, I will definitely send
But
you,
at
madam,
least
personally.
landmark guided, you can tell the landmark to the how the things are given
No, madam.
or by the diagram.
I just see the madam subclavian artery first, subclavian
Okay.
artery, and
Okay.
just make it proximally. The supraclavicular plexus is just superolateral to the artery, madam. You can give, actually I give the outer plane block. So initially, I generally go from the center of the probe, of the ultrasound probe, and I just keep probe the laterally, not in like
Do
transducer.
you
I
have
keep.
any landmark guided picture with you?
No, madam, I don't give landmark guided picture, landmark guided block, and I don't have madam picture. Sorry for that. I just
Okay,
give
madam.
because
To
I have
give-
USG
to give-
machine there, so generally we give either USG along with PNS.
Yeah, to give a
Landmark guided-
landmark guided block, supraclavicular block, you can palpate the interscalene groove in the at the level of Casanas tubercle, that is C6 vertebra, and you palpate the artery, that is the subclavian artery.
Okay.
Just lateral to the subclavian artery is the midpoint of the clavicle. If you
Okay.
join the first point, that is the Casanas tubercle in the interscalene groove, and this point, the midpoint of the clavicle, you just mark it and make a line.
Okay.
So just medial to that line will be the artery. You palpate the artery and go just perpendicular to the skin. That will be the subclavian perivascular.
Oh, yeah.
Huh? If you go just 1.5 to 2 centimeter above and go medially, inferiorly, and posteriorly, that will be the classical supraclavicular.
Yeah.
If you go medially, inferiorly, and laterally, that is along the nerves, the chances of hitting the artery also are less, and the safety margin is also better. So we also prefer to go laterally than go medially. The classical approach, we go medially. The modified approach is to go posteriorly and laterally along the nerves as it goes into the behind the clavicle.
Okay. Thank you, sir. Thank you.
Or one more thing you can do, madam, if you can palpate the supraclavicular artery and just above that thumb, if you are inserting the needle in 70 degree, you can hit the rib and you can give around 20-25 ml of drug there. So almost if you are hitting the rib also, you will get good action. Like generally, I also practice like this. I used to practice in my UG days where there were no PNS and USG guidance.
Yeah, that was if you don't
As
have a PNS or ultrasound.
Yes, sir.
as you make these blocks as simple, people can practice more and more. That's what I just wanted to say.
Madam, I'm writing a chapter on this. It will come in some days in the book.
Okay, thank you. We are waiting for you. Thank you.
It
Thank
was
you,
a very nice presentation, Videsh,
Thank you,
about
sir.
the myasthenia gravis and shoulderscopy. Only problem with shoulderscopy is the extravasation of the fluid, and sometimes it takes longer time, that 3 hours and 4 hours in some of the
Yes, sir.
scopies. Then you can have respiratory distress because
Yes,
the
sir.
fluid goes into the mediastinum also and compresses on the airway or track. So in that
Right, sir.
condition, general anesthesia was preferred with the block, so that
Yes,
you
sir.
have pain relief also and airway protection also. But for a shorter procedure of 1 to 1.5 hours, if you're not going to use a lot of fluid and the extravasation is less, then 100% you can go on with only
Yes,
the
sir.
block also can be done.
Actually, sir, I want to add one point here. So generally, our surgeon is very fast, sir. We finish all whatever the major tear is there, we finish it off within 2.5 hours, sir. And also we keep one cannula outside there. So whatever the fluid is there, it will get extravasated through that cannula and it gets collected into the back. So generally we don't get edema over the shoulder also. So that is the advantage at our center actually. That's why we are also going ahead. And definitely, sir, it is like ikde aad tikde vair kind of situation. Because interscalene block already blocks your phrenic nerve and your patient is lied down. So that side is also compressed. So definitely, sir, I am also just 8 to 10 cases I have done as of now. We are going ahead with more than I'll get to know about what are the complications.
So if you have done only 8 to 10 cases,
yes, sir.
I suggest that after the case is over,
yes, sir.
only under the block or with the GA also, do the
Sir, only under block I had given.
No,
sir,
do the
8 to 10
ultrasound of
cases
the neck
and,
again.
On mild sedation only takes. Sorry, sir.
No, do the ultrasound of the neck again and see how much amount of fluid has gone there.
Okay, sir. Definitely, sir.
You can do a
Thanks, sir.
study like this. That will tell you
Yes, sir. Thank you, sir.
within 1.5 hours how much amount of fluid is going there.
Yes, sir. Definitely, I'll see next time,
Sir, another concern in these cases is the hypothermia. So, a lot of irrigation fluids is used. The AC is on, so we have to monitor temperature along with EtCO2 and all, isn't
Madam,
it?
we generally keep the warmer on the back of the near to the legs of the patient, and it's not that much great problem. So okay, hypothermia can happen to anyone, but I didn't find any problem because I have done almost since last 3 years, madam. I have done around 500 to 600 scopies under general anesthesia. So I have not faced any like shivering and all post-operative, not in that much patients. Little bit hypothermic.
Currently lots of gadgets are come to warm up the patient. But when I am talking about 10-15 years back where the warmers were not there. So at that time we used to manage with plastic sheets. Sometimes
And
even
madam,
the electrical blanket also.
Getting warmer and getting warmer blankets and it is temperature probe at the basic setup is very difficult. At least we are having ultrasound, EtCO2, that is like more than enough kind of
Things are better now. So and the safety is also increased in anesthesia. So definitely patient's outcome is better. With whatever the patient may have, we can always have a plan A, plan B. And that becomes meticulous planning also helps for the patient better outcome. Yeah, thank you.
Thank you,
You have to keep hypothermia in
Thank
the
you.
back of the mind always,
Yes,
because wherever you are going to use the irrigation fluid in whatever surgery it is there, even if you are giving a good amount of lavage in the peritoneum, then also you should have the hypothermia in the back of the mind, because that can give a lot of problems in the post-operative
Yes, sir.
period.
Definitely, sir.
That was a very good point about hypothermia. I think so we can go on for the next lecture now.
Thank you, sir.
Yes,
I'm
sir.
stopping my screen sharing.
We'll
Thank
take the
you, sir.
questions at the end of the.
Okay.
Yeah.
Thank you, Mayuresh. Thank you, sir, for your expert comment. Now, our next speaker, Dr. Hemant Shirsagar, sir. So he is presenting the obese patient posted for the bariatric surgery. Okay. As we all know that there is an escalation. Sorry, 1 minute. As we all know that there is escalation of obesity in the world, especially after the COVID period. Obese patients need special perioperative care. When we do pre-anesthesia checkups, 50% of the tension reduces when we see the thin-built patient. We are very much scared of the obese patient. But our senior anesthesiologist, Dr. Hemant Shirsagar, sir, has very well managed the obese patient who was not of 100, 150, but 210 kg. Sir, that patient was obese patient was posted for bariatric surgery. And now with this case, obese patient posted for bariatric surgery, Dr. Hemant Shirsagar sir will present this case. Dr. Hemant Shirsagar sir is a consultant at Ankur Super Speciality Pain Clinic, Chinswad, Pune, Pune International Burn Center, Bhosri, Dinanath Mangeshkar Hospital, and Jupiter Hospital, Baner. Sir did his MBBS, MD, FI, APM. He is a pain physician. He did diploma in critical care medicine. He is an interventional pain specialist. He is a fellow in burn care. I request Hemant Shirsagar sir, kindly start your presentation.
Hello, very good evening to all. Thanks, madam, for those kind words. I am audible to all?
Yes, sir.
Yes,
You are
yes.
audible, sir.
Yeah, but
Audible, sir.
my slides are not visible.
Not yet.
Yes, they are not visible.
Just
sir.
a minute.
Sir.
Now is it visible?
Yeah, make it full screen, please.
Yeah, I'll make it full
Yeah,
screen.
visible, sir.
Yeah, is it okay now?
Yes,
Is it visible? My slides are visible to all?
yes, sir.
Yes,
Yeah.
yes.
Yeah, thank Mayuresh. It was really a very
Yes,
wonderful
visible.
case. Yeah, thanks a lot, man. Mayuresh,
Thank you, sir.
congratulations for successfully conducting such a wonderful case. As a freelancer, as a private practitioner, it's really salute to you that you have managed this case very nicely without any problem.
Thank you, sir. Thanks a lot.
Regional anesthesia. So greetings from my side.
Thank you, sir.
So my case is already madam has told. He is almost 28 years, a young chap. His weight is around 210 kg. Possibly body mass index is around more than 70. Roughly it would be around 73, 75. Patient history, that patient came with complaining of bilateral pedal edema, complaining of little bit difficulty in breathing. Then now he is getting more problem with the daily performing his routine activities. On examination, his blood pressure is that way he looked better without any medical problem except his obesity. Blood pressure is around 140, 100, pulse rate is around 100, is a febrile saturation, on air is around 95, 96. Cardiovascular system is normal, central nervous system is conscious, well oriented. Air entry, it's very difficult to hear in such a obese person, but okay, air entry equal on base, on the upper part, basis is very difficult to hear. Per abdomen soft or no any adverse history for this chap. On investigations, his hemoglobin most of the time biochemistry is normal, CBC is normal. Just a minute. Hello. Okay, thank you. His platelets is around 3.84 lakh. Sugar is also in a normal levels. Electrolytes normal. His pro-BNP is almost 431. D-dimer is 536. Everything is in the normal range. 2D echo, color Doppler of both arterial and venous of lower limb, they also normal. So this case was posted for laparoscopic sleeve gastrectomy. So this was my patient. He is almost looked at 210 kg. He's sitting on the OT table. Look at how he is breathing. So now he started walking. This was the picture after the surgery, after 6 to 8 hours. So this was the intraoperative picture. So to do these all type cases, we need to do all these things. Your fundamentals should be very, very strong. Your preparation should be at the optimum level. Even though your fundamentals and preparation after even the execution is that way is very important. So what are the things which comes under fundamentals? So anesthesia for a bariatric surgery, I don't say it is war because most of the nowadays we are getting a lot of obese patients. So possibly as an anesthesia and as a surgeons, it's very difficult to manage these cases. So if you look at the fundamental side of the obesity, in our entire world, 7% population is possibly suffering with the obesity. Recently, it is a global health issue. It has got some socio-economic variation also, and nowadays because there is an increase in the childhood obesity. So body mass index, according to the WHO, now this is new grading which has laid down by the WHO. Less than normal, it is a normal body mass index. If patient is obese, if his body mass index is 30 to almost 35, obese again class 2, body mass index is 35 or 40. Morbidly obese, that is a class 3, which is body mass index should be more than or equal to 40. Super obese, we can call him if his body mass index is equal to 50 or more than 50. And any person who is above 60 body mass index is a super obese. So this is the picture of a normal. This is obesity. This is again morbid obese, super obese. So to calculate the doses, we need to do fundamentals right in the calculation of the what is meant by body mass index, how we need to calculate the body mass index. So to calculate the body mass index, we need to calculate the total body weight in kg divided by height in meter square. To calculate ideal body weight, these are more sensitive formulas. For specific formulas, we need to find the regular academic books, but this is what is very simple formulas to calculate the ideal body weight. Height in centimeter minus 100 for men, height in centimeter minus 105 for women. To calculate the lean body weight, we need to calculate lean body weight in the form of ideal body weight into 1.3 and the projected body weight for the ventilation. So there are a lot of medical issues with the obesity. Every system is getting affected because of the obesity, including your pulmonary system, liver, then the abdomen, then your osteoporosis, bone tissue health, central nervous system, cardiovascular system, a lot of other things which can come up with the obesity. Like most of the cancer, people used to say obesity leads to breast cancer, colon cancer, or prostate cancer. So sometimes this obesity leads to intracranial hypertension in the form of stroke. Sometimes because of the obstructive sleep apnea, hypoventilation syndrome. Then there is a coronary heart disease which leads to diabetes, hypertension. And lastly, as I already told regarding the cancer, breast, uterus, cervix, colon, esophagus, pancreas, kidney. For the fundamentals, again, this is very important. In obesity, we as an anesthetist or airway management expert, we should be worried about the intubation or airway consideration. So always consider difficult intubation, look for examine the neck of the patient. Most of the time they have a short neck, they have a limited neck mobility, maybe because of the fat, they have a retention tissue around their neck. You should also ask patient to the drug history because nowadays they used to take glucagon-like peptides and they should be stopped 1 week prior to the surgery. Intraoperatively monitoring, we need to connect with the standard monitors. If at all patient is having some cardiac element or old age, we can use a heart line or arterial line, ETCO2, or adequate size blood pressure cuff. So what are the consequences, especially we expect in a obese patient, though he is not having any cardiac issues, like in the form of arrhythmias, pulmonary embolism, sudden hypertension, myocardial infarction, or sudden deaths are also very common with the obesity. Regarding the respiratory system, there are a lot of physiological changes that happen because of the obesity. What is that? There is a rise in basal O2 consumption plus more CO2 production. That is a fall in the lungs and chest wall compliance because of the fat. There is a rise in the airway resistance, fall in functional residual capacity. Because of the obesity, diaphragm pushed upwards like a pregnancy, and it is very difficult to lie this patient in a supine position. So this entire thing leads to results in the lung collapse, ventilation perfusion mismatch, and impaired oxygenation. So the tidal volume, either it's normal or reduced. IRV, it is mostly reduced. ERV, mostly reduced. FRC is greatly reduced. FEV1, sometimes it is normal or it is also reduced. So most of the time, it is very important to ask the history of obstructive sleep apnea. How obstructive sleep apnea affects the physiology of the patient. Obstructive sleep apnea present in 5% of the obese patient. Most of the time, patient gives history of snoring or daytime sleep or somnolence. Dry mouth. Regarding the gastrointestinal system, there is a rise in intra-abdominal pressure. rise in a gastroesophageal reflux, presence of a hiatus hernia or GERD. Then most of them, sometimes this obesity comes with the diabetes and they have gastroparesis maybe because of autonomic imbalance. And this entire thing leads to aspiration. So we should be really very energetic to manage all these things. Now, once your fundamentals are cleared, now this patient come to theater for the bariatric surgery. So now the preparation is very important in such case. For the preparation, as already mentioned about the CPCs, electrolytes, RFTs, LFTs, thyroid profile, blood sugar, lipid profile, coagulation profile, or sometimes cortisol levels. Again, if in the investigations, pulmonary function test, 2D echo, chest X-ray, ABG, CT angio, stress element, focus is very important to rule out the how much is the gastric volume even after a patient. We keep this patient NBM for 6 to 8 hours. But nowadays, the WHO recommends at least 10 to 16 hours NBM is required for a bariatric surgery. Those patients who are having their body mass index more than 50. This point of care ultrasound is very important, especially abdominal focus is very important because nowadays most of the hospital they are now having a sonography machine. So preparation again, admission, on admission, look for the use of CPAP or BiPAP, oxygen supplementation, nebulization or liquid diet. DVT prophylaxis in the form of mechanical or in the form of pharmacological. Regarding the drug metabolism, it has got, if a simple physiology, just keep two things in mind. One is they have an increased volume of distribution, and that increased volume of distribution and those drugs which are more lipophilic, they will take more time to metabolize and get excreted from the body. Regarding the inhalational agent, considering all the aspect, people used to say sevoflurane is the safer as compared to isoflurane or desflurane. So we need to have a very good backup system in the form of ICU or in the form of OT. And you need a good team to manage such type of cases. Without team, you cannot do all these cases. So your HR department should be very strong to manage these cases. At least in a theater, we should have 8 to 10 people around you and which are expert to handle all these things. OT table, this OT table, bariatric OT tables are very important because they used to handle almost 250 to 450 kg of a weight, and they have a very nice mobilization or automatic control tables. These are the patients. In OT, we need to have all these monitors. Cannulation is very important because these patients are very difficult to take a simple IV line. But nowadays, because of the ultrasound, we are using ultrasound to take a simple IV cannula. Calculation of the drugs. So in previous slide, I mentioned about the total body weight, ideal body weight, lean body weight, and projected body weight. Just to remind you, only these three drugs are required to calculate according to the total body weight. Or rest of the drugs we need to calculate either with the ideal body weight or lean body weight. So we need to calculate total body weight for the scoline, rocuronium, or sugammadex. So in OT, we need to give reverse tendon position, head up position. So this is really very difficult task, induction and intubation. So this is the flat patient. Now this is what we can call it as I forgot the name of this position, but possibly it is known as
ramp up position, sir.
Ramp up position. So this is the real picture of the vocal cord of the obese patient. So this is we need to have a positioning is also important in such patients. So we need to have all these equipments in your hospital to manage this type of cases. So ventilation, prevent atelectasis, use FiO2 of less than 0.8, use PEEP, it should be 5 to 8 centimeter of water. Tidal volume is around 6 to 8 or 10 ml per kg of a projected body weight. Mild hypercapnia is acceptable. Regarding the fluid management in this case, you should always worry about the rhabdomyolysis and acute tubular necrosis, that will be because of the rhabdomyolysis. Limiting preoperative fluids on GI recovery and hospital stay. Mostly urine output is an unreliable indicator, but used to say 0.5 to 1 ml per kg per hour is the important thing to have adequate fluid. But basically, these surgeries are lasting not more than 2 to 2.5 hours. So IV fluids we should be little bit given in a calculated manner. So this is really a tough job, that is extubation. So I always feel as if you are doing a surgical strike part 2. So this how I extubated this patient. Patient is little bit awake. He is in little bit head up position. So post-operative, we need to give propped up position, maintain airway, either with the oral airway or nasal airway, respiratory support in the form of CPAP. They need to have a good pain control, oxygen supplementation, and continuing the use of DVT pump. So to conclude my talk, what I'll say, there are a lot of life-threatening mishaps intraoperatively or post-operatively. It is a teamwork. We need to have optimum preparation. We need to inform high-risk consent to the patient and relatives. The proper case selection is also important. So these are the some mishaps, life-threatening complications like in the form of Titanic. Then we need a very good team, as if we are working in a ISRO women scientists. They made really a beautiful thing. This is a proper thing to have optimum preparation, informed consent, and a proper case selection. Thank you for patient hearing. Thank you.
Thank you, sir.
Yes, is open for the discussion.
Such an informative lecture it was, and I know that how much stress you must have been that time to handle this case. Thank you so much. I request Dr. Sandeep Mutha sir to give his expert comments.
This one, Hemant, can I ask one thing? Like this
Wow,
patient is
please.
very nice discussion, and patient itself was very horrifying to a normal, or somebody feel like running away from such patient. Maybe if I was there, but then how do if this patient comes in some other odd position, like you manage this patient in the supine with the OT table, specially prepared for such patients,
Yeah,
250
it's
to
for the bariatric table.
bariatric. But if such patients come for any other surgery with an odd position, like lateral, how do you manage these patients?
Odd positions for what? For the intubation or for the surgical?
No, for the surgical position I'm talking about.
So basically what I'll say, see, we need to anesthetize to do all these procedures. That is the most important thing. And what I'll suggest for obese patient, either you start using CPAP machine or a BiPAP machine. With this, they will tolerate this thing. And once they settle with the oxygenation and ventilation, I don't think so there will be any issue. Except table should be optimum here. That patient table should bear weight of that particular patient.
Can you think of any regional anesthesia for a post-op anesthesia for such patients? Can you think of?
Honestly, see, basically now these surgeries are mostly a daycare surgery. Patient remains in the hospital for only 1 or 2 days. And to give regional in this patient is really very tedious job, and it's very difficult thing to have. And these all are laparoscopies, so there is hardly any pain to give regional anesthesia. But nowadays we are doing like either a TAP block, UVG guided TAP block, or most of the time surgeon used to give TAP block intraoperatively or postoperatively after the completion of the surgery. So TAP block.
Shubha madam. Yeah, Hemant.
Yes, sir. Yes, sir. Please go ahead, sir.
Yeah, to have a good pain relief in this type of obese patient where the regional anesthesia is normally difficult, you can give electrospinal block or TAP block if you require. But it's better to go by a multimodal approach. And in that one also local anesthetic plays a very good role. So if you can start with infiltration of the ports, before the ports are taken, the subcutaneous infiltration and up to the peritoneum. That is the parietal peritoneum, which has the sensory fibers. That is the first part of the analgesia. Second part of the anesthesia is to have a good depth of anesthesia. If your depth of anesthesia is not adequate, then the postoperative pain is more. The third part of analgesia in these bariatric patient is the basic pain is because of the splitting of diaphragm. That means because of the pneumoperitoneum, there is stretching of the diaphragm and there is splitting of the crux of the diaphragm. That is causing the pain which we know as a anginal pain or a shoulder tip pain. So to prevent that, you can instill a very diluted local anesthetic just above the liver under the diaphragm in a larger quantity at the end of the surgery or at the beginning of the surgery, but we normally prefer at the end of the surgery. If I follow this type of regime with NSAID and a very low dose of opioid at the starting of the surgery and infusion of dexmedetomidine, if we follow this type of regime in these patients, literally means what bariatric patients I do, I make them walk in 15 to 20 minutes after the surgery is over. So they go down from the recovery room to their room after half an hour walking. They are never taken on stretcher or the bed. Hardly around 2% of the patient will be taken because they don't walk in the preoperative period only. So those patients are taken. Otherwise, most of them won't require any stretcher or a bed to shift. So if you give this type of analgesia, that is a multimodal analgesia to these patients, it is always go. So your recovery is faster and your discharge is also less faster and your complications are less. Hema, that was a very good lecture discussion, but I wanted to ask you,
Thank you, sir.
what will be your goals in preoperative preparation of these patients if they have some metabolics like diabetes, hypertension, and the OS is there with a AHI of around 40, 50.
So what I'll
And
suggest
their
to
minimum
my
saturation
surgeon
during
is-
sleep is going to around 70 or 80.
So what
So
I'll
what will be
suggest
your
to my surgical friends and most of the time what I'll suggest him to admit this patient at least 10 to 15 days prior to the surgery. First thing. Second thing, I tell them to put them on a liquid diet at least for 8 to 10 days. By the time they will lose at least 8 to 10 kg in that particular 10 or 15 days. Third important thing, I will, as you very nicely asked about regarding the obstructive sleep apnea, I will ask them whether they are using machine at home, or I will basically most of the time their relatives gives history of that patient is snoring daytime, he's most of the time sleepy and all. So in that matter, I will ask them to use that machine, BiPAP machine in the night. Then I will check for his ABGs, how much his CO2 level or O2 level goes once he sleeps or in the night. Third thing, most of the time is good hydration, nebulization. That's what we can advise to them, sir. If you want to add anything about on this.
Would you be doing a sleep study in these patients?
That is, I have not advised sleep study. Better, we need to advise sleep study about this patient. Yes, sir.
So if the easiest way of checking for the OSA patients is the bedside, that is a stop bang
stop bang
question, stop
yes,
bang
yes.
this one. If in that one it comes as a severe this one and your basal saturation is around 90 or sometimes 88, 87 also, and the patient is a little bit tachypneic, his breath holding time is low, and the PFT is showing a severe restrictive lung disease, it's better to go for a sleep study and check all the parameters.
Okay.
Because medico-legally it will be required to do the
Yes,
sleep
sir.
study in these patients.
Yes, sir. Yes.
Not
thank
only
you.
medically, for our this one also.
Safety also it is important, sir. Yes, sir.
Yeah.
There is one question in the chat box. Can we take that?
Yeah, I think so. If we can go off the slideshow, then we can see everybody.
Yes, sir. I will stop this, sir. Okay.
There is one question, sir. What about myopyrrolate? I don't have Sugammadex. Maximum obese patients I regularly doing 120 to 150 kg. They need more drug. What about myopyrrolate? They are asking. You have given Sugammadex. They are asking about myopyrrolate.
So regarding his doing these cases only for the bariatric surgeries or any other surgery?
They just said that I have regularly doing patients around 120 to 150 kg.
Then you can use myopyrrolate is a really good drug of choice. Now we have a luxury to use rocuronium and Sugammadex. Otherwise, previously we are only using myopyrrolate. Even Muthasar is also using that before coming this Sugammadex.
So
mostly
basically,
Dr. Raksha,
basically,
Raksha is asked, you can unmute and you can ask Dr. Raksha. She's doing it for plastic surgery cases. That's why she has written.
yeah, Raksha, if you're doing it for the plastic surgery case or any surgery where you're giving general anesthesia, you can use rocuronium succinylcholine combination, or you can use cisatracurem and neostigmine combination. But in that one, the neostigmine requirement, if you're going to you're going to have a patient of 150 kg and more, you may go up to 3.5 milligram of neostigmine. If you give, let the patient come out a little bit, start breathing. If you have a neuromuscular monitor, it should show at least
plane of flow response should not
and
be.
then you reverse with 3.5 milligram of neostigmine. In a patient of more than 120 kg, it is recommended to use 3.5. Less than 120 kg, you can use 2.5 milligram also.
Hello.
So only the dose of neostigmine will vary.
So simple suggestion, what I
dose
can
of-
suggest, always delay the extubation in obese patient. Give some time for them.
Delayed extubation is it is the dictum in obesity is
Dictum,
delayed
yes.
extubation is better than re-intubation.
Re-intubation. Because once they become violent, it's very difficult to handle them. Things go beyond your control.
Thank you. Thank you, sir.
Hemant, you said about the desflurane. How about like most of the OTs don't have desflurane? How about working with the sevoflurane, sir?
I'm very confident with sevoflurane because in most of the hospitals, sevoflurane is now easily available. Desflurane, they used to say it has got very, I think blood gas coefficient, yeah, lipid soluble coefficient is, I don't know the exact figures, and probably they used to say desflurane is good as compared to the sevoflurane. But we never used desflurane because it's not available. But we are comfortable with the sevoflurane. I think Mutha sir must have used desflurane. He can tell more about that.
Okay, I have used both and I'm using still both desflurane and sevoflurane. For a case of less than around 4 hours, desflurane and sevoflurane don't have any difference. That means the patient coming out of the agent, the cognitive function and everything are same. If the surgery is going to go more than 5 hours, then a little bit of accumulation of sevoflurane is there. So in that case, or in any case, at the end of the surgery, you have to do something known as coasting. Coasting means you keep your low flows on, you stop nitrous, take it on air oxygen, stop the agent, and let the agent concentration come down slowly to the MAC awake. So this is only when you have a agent gas monitor and the MAC. If you don't have that, keep the low flows on, decrease the agent concentration, and at the end of the surgery, then you can increase the flows and everything will be drained out. So the patient coming out of sevoflurane and desflurane will be almost similar in a surgery which is not lasting for more than 4 hours. And I have done the study of the coasting with sevoflurane and coasting with desflurane. After 2.5 hours of surgery, both took 10 minutes to come down to the MAC awake, that is 0.4. So there is no difference in sevoflurane and desflurane in this condition. But for the safety, this one, for a very super obese patient, we still use desflurane. For a patient of 180 and less kg, we use either sevoflurane or desflurane, whatever is available or whatever you fancy on that day.
So sevoflurane always give the post-operative agitation, like post-extubation
No, madam.
agitation. So how do
No, madam. If you do coasting, if you slowly remove the sevoflurane out of the body before extubation, that is 10 minutes are you're taken for slowly removing sevoflurane out of the body. The agitation is very less or it is not there. Only in a very muscular patient, you can still get a little bit of around 3 to 4 minutes of agitation, and after that the patient will settle off. If you don't do coasting and your sevoflurane is not completely out of your body, or almost 90%, not out of your, only 90%, 10% still remaining inside. Your MAC awake has not been achieved. Then you will get this post-sevoflurane agitation. Otherwise, you won't get it.
And
And
that
I've
is
seen the
more common
agitation
in
is there.
children, I think.
Children,
The
yeah.
agitation,
I think.
post-sevoflurane agitation is more common in children.
Though it
No,
is
madam, in
transient,
children
it
also
is
and
a
muscular
problem.
obese also. In non-muscular obese, the fatty obese, you won't get it. But in a muscular obese, 100%, 100% in many of the muscular obese,
Many.
you do get it. But only if you do coasting, means the incidence has come down from, it was supposed to be around every 15 or 16 cases, one patient used to get a little bit agitated for 4 to 5 minutes. But after starting coasting, it is minimum number is there. Means I can say in 50 only one patient is getting agitated sometimes. Only today one patient got agitated because I didn't remove his tube very fast. I was not happy with his respiration. So I just waited. He was opening his eyes and everything. I removed the tube. He got agitated for some time, but that was not because of sevoflurane. That was because I had delayed his extubation. And he was also around 240 kg or something. So basically in obesity, Hemant, what do you suggest? During intubation and during extubation, should we have the same position?
In fact, sir, for extubation, I will give little bit more head up or reversed Hindenburg position.
Okay.
For extubation, not for intubation. And over the time, what I realized is, sir, almost most of the time they have a very easy intubation. They look difficult, but while doing scoping, it looks very easy, honestly speaking.
You don't give a ramp position, it will become difficult.
That's true. That could be one more thing. So, yes, sir.
Yeah. For everybody, this one, if we do a ramp position, the intubation of the obese patients is not difficult unless and until they have got cervical spine issues.
Cervical spine. Yes, sir, right.
So otherwise, the intubation is not difficult. Only thing is that what size of blade you are going to use, because mentohead distance sometimes can be 9 or 10 centimeter also.
Extra large blade.
So if the mentohead distance is more, then you will have to use a larger blade. And rarely we require a bougie also to introduce the endotracheal tube. But the recommendation is while extubation also you give the ramp position and a head-up position before extubation, because you have to be ready for re-intubation.
Re-intubation, of course.
So if you don't give a ramp position during extubation, the difficulty will increase.
Yeah, of course.
And what
Do
is the
you
comment
manage,
on nasal airway?
sir, do you, how about lung recruitment manuals for such patients?
So basically, for the lung recruitment monitors in the institutional setup, we have a very good anesthesia workstations. We can give CPAP, we can give PEEP and all. But we are as in small setup where we are doing the cases, they don't have good anesthesia machines or stations. So in that, what I'll follow the every 1 hour, every 45 minutes to 1 hour, I used to take the bag in my hand. I will increase the inspiratory pressure as if I am giving a Valsalva. And this
Squeeze the
will
bag, yeah. Squeeze the bag.
squeeze the
Squeeze
bag.
the bag.
As if
So
I am
that
giving
was
the
the thing
Valsalva.
we were trying initially, earlier also, before extubation.
Yes. Really, this is a very good suggestion, madam. Even you can do this maneuver for now. Most of the time, they are doing laparoscopic surgeries in head-low positions. So this is really a helpful maneuver.
So you take the bag in the hand.
Yes, sir.
You put it on 80% or something FiO2 with the higher flows.
Yes, sir.
Take the APL wall to around 40.
Yes, sir. And then
And then
squeeze the bag.
Squeeze the bag for how much time?
Possibly, sir, 10-15 seconds.
Okay, the recommendation is to squeeze the bag for 15 seconds and then leave it again. You can do this maneuver twice.
Twice, yes,
but
sir.
if you are doing it on the machine, then you can do a vital capacity maneuver.
Yes, sir.
In the vital capacity maneuver, you again take the APL to, or not APL, you tweak the maximum pressure to 40,
What?
PEEP of 10,
Uh-huh.
increase the flows,
Mm-hmm.
and the IE ratio of 1:1, and the
Mm-hmm.
respiratory rate of 4.
Okay, I
So
hear
in the
it.
respiratory rate of 4, that means 15 seconds is one respiration,
Yes, sir.
7.5 seconds of inspiration, and 7.5 seconds of exhalation. The tidal volume should go 2.5 times the normal tidal volume without
Okay.
changing the hemodynamics by more than 10%. This was the recommendation if you
Yes,
are
sir.
going to use a vital capacity number.
That is on the
And if
machine.
if you don't have a sophisticated anesthesia machine, then you can take it on hand. I have tried both the things, that just squeezing the bag and leaving it for 15 seconds and then leaving. And the second thing which I tried to do after that was squeezing the bag and giving a small tidal volume of 100 ml with a
Okay.
higher frequency with the hand only.
Mm-hmm.
So, like if you are going to blow the balloon, if you blow the balloon continuously, it becomes very difficult.
Exhausted. Yes,
If you
sir.
blow the balloon slowly, it inflates very fast.
Yes, sir.
Yeah.
So that way, if I give a tidal volume of 100 ml with that increase in the pressure, the lungs open up very fast.
Yes, sir.
Yes, ma'am. Shobha, madam, correct?
Yeah, two good new things we have learned, ghosting and maybe your vital capacity monitor. Yeah.
I think
Yeah.
this is acting as a CPAP, sir,
Yes, sir.
like a
Yeah.
CPAP.
Mm-hmm.
And
Continuous.
one more thing is there in extubation in obese patient, you have to extubate, or not on obese patient, nowadays it is recommended for all the patients. You have to extubate at a CPAP of 5. So you have to keep the APL wall to 5
5 centimeter of water.
and keep the oxygen on and remove the tube with the circuit on. And then put the mask so that the lung doesn't deflate.
Mm-hmm.
So atelectasis is less if you do this. So this was the newer recommendation by, I think SIDA only gave this recommendation of using CPAP during extubation.
Right, sir.
Uh,
I'll
I
definitely
wanted to
try.
ask about the thymus patient. If you want to use a relaxant, which will you prefer now? Rocuronium Sugammadex or Cisatracurium neostigmine?
Rocuronium Sugammadex, sir.
Where is this? क्या नाम था उनका?
Mahirish.
Yes, sir.
Mayuresh.
Yes, sir.
What do you recommend? To use Cisatracurium, because Cisatracurium is not going to get, you don't have to give reversal also, actually speaking, but we still give. You don't have to give reversal, and the block will be over in the due time.
Sir,
So you can
whatever the articles I have read, in that they have written Sugammadex, Rocuronium can be used very well in case of myasthenia gravis patient, because almost 99 to 100% Sugammadex can reverse the myasthenia gravis muscle relaxant. Regarding Cisatracurium, sir, to be frank, I don't know about the Cisatracurium.
So
But
what our teaching was there in the college was to use Atracurium for myasthenia gravis patient.
Yes, sir.
So from that we can use Cisatracurium, which is better than that.
Yes, sir.
Yes, ma'am. Shobha, madam. Nilavati, what do you say?
Sir, I also think that because we are giving anyway anticholinesterase to these patients for this myasthenia, that is pyridostigmine and all, I think this will be better, sir, myopyrrolator, that is neostigmine and atracurium combination.
Actually, both are good. Means Rocuronium Sugammadex combination is also good, and Cisatracurium and neostigmine combination is also good. So the general anesthesia has become safer in myasthenia patients now.
And we can
because of this
increase the
combination.
dose of that myopyrrolate, that is neostigmine.
Madam, it is seen in Mayuresh will also this one. We have seen that some of the patients who are on pyridostigmine, they come out of relaxant very fast,
Mm-hmm.
and some of the patients don't come out very fast. So both the types of patients are there. I mean, though they are on pyridostigmine, some of the patients, means if I give Atracurium or Cisatracurium, within 10 to 15 minutes they will start breathing, or even Rocuronium. And some of the patients won't breathe for 1.5 hours also.
Is it
So how many
depending on
patients you have come across, sir, about it's a rare condition, myasthenia. Like in my whole career of 42, I did not get any patient, truly speaking. But some patients, like how I said, occult. Maybe they took so long to come out in spite of lower depth sevoflurane monitoring and adequate MAC value. But many a times it happened like that. Then I thought there must be some entity like prolonged muscle relaxant in spite of normal dosage. Have you come across with such condition anytime?
Yes, with the initial agents which we were using, that is vecuronium and vecuronium, basically, it used to happen that they don't come out very fast. But atracurium or cisatracurium, they come out in time, or a little bit more time is required in these patients.
Sometimes they need plasmapheresis also, no, sir? Sometimes they are so much resistant and they are not coming, then they need plasmapheresis also.
Madam, we have done so many thoracoscopic thymectomies, means never we have required of a plasmapheresis with this type of combination.
Okay.
So with atracurium, cisatracurium, they come out very well. With rocuronium, sugammadex, they come out very well. But with vecuronium or Pavlon, which we were using earlier, sometimes they used to give Pavlon also. Then it was a big problem. Then sometimes I had to ventilate one patient in Sassoon for around 4 hours for it to come out slowly. So that is a possibility, but you can.
But basically, this depends on the dosage of physostigmine and steroid. What type of dosage they are taking?
Preoperative doses, what they are taken.
If the physostigmine dose is more than 700 milligram, then things are really problematic. If it is less than 700, I think it becomes easy that to manage. And now, as sir already told, because most of the time these people are doing thoracoscopic thymectomy, it's really wonderful surgery for this. They'll get extubated on table and they'll get discharged within 3 days after hospital admission. So now things are very nicely available, but I'll still suggest you can start using rocuronium, vecuronium, or sugammadex. Even these two, sugammadex is
now sugammadex is available very well.
it's easily available and the cost is hardly 600 rupees.
800.
But
The MRP.
No, less
800.
than that. Less than that.
No, MRP.
URC is 700 rupees.
With the competition, the price is reduced. I mean,
because
many.
of sugammadex, again vecuronium coming in the market.
Yeah.
Vecuroniumची cost आणि त्याची cost बरोबर होते.
Okay. Both the speakers were so nice, like they were enlightened about the critical condition, not so common, rare condition. I really congratulate Hemant as well as Mayuresh. It was very nice, and the key advice with Dr. Sandeep Mutha, like coasting. First thing I have learned about coasting and ventilator. You said about the
Lung
ventilator.
recruitment.
1 word, yeah, recruitment. Thank you, sir. Thank you.
Thank you, everyone.
Just last question. I just wanted to know, not
what?
particularly about this 250 or 220 case. In obese patient, maybe 125, 130, what type of fluid you prefer, Hemant?
I used to, madam, RL or plasma light.
Okay.
No, this is best way.
Not something
No.
different or.
These are good.
Okay. Routine, whatever we use for routine. Okay.
So nowadays, madam, every patient is almost 100, 110 kg. So
That's what.
With the IT boom in the PCMC area and Hinjawadi and nearby, Hemant, do you advise trace element? There's your examination of the trace elements you said in your,
So
in your
basically,
presentation.
madam, what happened because of these patients are coming from the surgeon's OPD. So surgeons, they advise everything that they should not land up in a court of law. So they have not left anything without doing any test. So trace element possibly they used to see for magnesium or phosphorus. They must have seen because of the obesity, these trace elements may be on the lower side. That could be this is the only explanation I can give. Otherwise, I don't think so there will be any required explanation for this.
And they give supplements of trace elements.
Trace elements to them.
Yeah.
You
Because
said
they
something
have
about the
a-
projected body weight. What is that? Projected body.
Body weight, I forgot the exact formula, madam. But they're using it for the ventilation of the obese patient. It is different from ideal body weight, lean body weight, and total body weight. Let me find
Madam, the difference is The difference is the lean body weight is the body weight without the
Fat.
fat weight.
Hmm.
But there is around 20% of the fat which is a normal fat.
Normal fat. Okay.
So normal fat. Suppose you have total body weight is 100.
100. Huh?
The lean body weight was 50.
50.
So 50 was the fat weight. 20% of that 50 fat weight is taken into account in calculation. So that is the adjusted body weight.
Okay.
So in the adjusted body weight, 20% of the fat weight is also added.
Hmm.
So you have to calculate according to the adjusted body weight. And very simple formula for calculating the drugs, like he had also said, Himan, that's succinylcholine 150 milligram, that is the maximum which we can give. But all the drugs which act immediately, they are not going to get redistributed in the fat because the blood supply to the fat is very less.
Very negligible. Yes, sir.
Normal blood supply to the fat is 2 ml per 100 grams. The increased fat which is there, it gets only 0.1 ml per 100 gram blood supply. So the drug is not going to get distributed there, but it is going to act in the places where we want. So all the drugs which are going to act immediately, that you have to give by the ideal body weight or the adjusted
Total
body
body
weight. The difference is not much. And the drugs which are lipophilic and for acting for a longer time, that had to be given by the total body weight. In that one, I think so atracurium was also there, but still we give atracurium as the lean body weight only. So you can calculate the drugs according to this also, that immediately acting, shorter acting like succinylcholine or even propofol, which you are going to give as an induction agent, that you can give as a adjusted body weight. And if you are using propofol for maintenance, then it has to go by the total body weight.
Hemant,
So-
you said about the table structure, like the specialized table meant for the bariatric surgery.
So
If
basically,
like
madam, we have reverse tendon mark position as if your patient is standing. So we need to have the leg support. We need to have a wrap around the patient. It should be very easy to handle actually. Automatic tables with head low, head up. Hydraulic tables.
yeah, but in a like a routine OT, if you don't have and a patient of 150 kg comes, can
I
we?
think,
I mean,
madam,
how
with-
much is the normal weight bearing capacity of
I
that
think
table?
normal table weight bearing capacity is hardly 200 kg, not more than that. Our normal routine tables. But it's a maximum number. That does not mean you should keep the 200 kg patient on that table.
The labor
Because
room
of-
table which we have, the labor room tables which we have has a capacity of 125 kg only. The OT tables regular which we have is 250 kg. And what we require for bariatric patients is 400 kg.
400 kg.
So these are the three types of different types of tables which were available. There is labor room table that has a central this one and goes up and down. That takes only 125 kg. The regular table which we use in the OT, which is electronically controlled and hydraulic, that goes to around 250 kg. And bariatric table goes to 400 kg.
450 kg. Yes, sir.
Thank you. Thank you for a nice
Good,
discussion.
good. Very nice. Excellent presentation by Hemant and Mayuresh. And thank you, Mutha sir. It was wonderful discussion and we enjoyed. Even being in Calcutta, I enjoyed your session.
Now I
Thank you.
request Dr. Bhageshri
Calcutta is a nice
for
city,
vote of
actually.
thanks.
Yeah.
Bhageshri.
Thank you, Nilavati. It's an honor to present the vote of thanks. I would like to thank our today's chairperson, Dr. Sandeep Mutha sir, for sparing his precious time for our webinar and providing with all the practical tips. So many new things we could learn today because of you, sir. Thank you so much. I would also like to thank our SAMs who are providing us this platform every month to do these webinars and getting enriched with the knowledge. Thanks to our today's speakers, Dr. Hemant Shirsagar and Dr. Mayuresh Umalkar, for enriching us with these special cases. We don't see these types of cases on our day-to-day basis. So it's quite good to have these kinds of discussions to, in a while, to get prepared for this. Yeah. Thanks. And thanks to Nilavati also for wonderfully moderating the sessions. And thanks to all our participants who make this webinar a success. So all our seniors, Dr. Maya ma'am, Bhavesh, Uma madam, thank you for arranging such kind of webinars. With this, I announce that our webinar is concluded.
Thank you so much.
Thank you, Bhageshri.
Thank you.
And
Thank you.
there,
Thank you.
from
Hello.
tomorrow we are having elections, so everybody please cast your right for the national
Yeah,
elections.
cast
अभी
your
किसको
vote.
दे
Yeah.
किसको देना है ये मत बता, by the way.
पता ही नहीं है कौन है. Thank you, sir. Thank you so much for
Thank you, sir.
Good
Thank
night,
you, Mutha
everyone.
sir.
Yeah.
Thank you.
Thank you, sir.
Yes.
Thank you,
Thank you,
everyone.
everybody.
And good night.
I think we
Especially
conclude.
Dr. Mutha, who accepted it at a very short notice. Thank you, sir.
Absolutely. I think we'll wind up. Good night, everyone.
Good night, everyone.
Leave meeting.